back, everyone, to our latest episode of the SOAP podcast, Spotlight on Advocacy and Policy, which is an ACRO podcast series. I'm excited to be talking about the latest ACRO Insights article today with one of my co-hosts and several guests. So I'll let everyone introduce themselves as well as what ACRO Insights is all about.
Thank you, Dr. Brown. My name is Tarita Thomas. I am the chair of the Government Relations and Economics Committee and really glad to be here to discuss this latest ACRO Insights about the development of the Medicare Physician Fee Schedule. And we have our other guest today, Dr. Wallner.
Paul Wallner. I've been involved in radiation oncology and national healthcare health policy issues since the early 1980s. Represented ACRO, ASTRO, and the ACR on the CPT editorial panel, RUC, and on the Medicare ambulatory payment classification panel, where I chaired the subcommittee that developed the policy for hospital charges.
Teri?
Hi, I'm Teri Bedard. My background is a radiation therapist. I work with revenue cycle coding strategies, and I've been providing support over the last several years with the GREC and that for coding reimbursement information related to radiation oncology.
Jason?
Jason McKitrick, Liberty Partners Group, and I've been ACRO GREC staff for quite a while. Liberty Partners Group has been supporting the ACRO lobbying and government relations activities for probably about 20 years at this point.
Excellent. So I think first we'll get started with an overview of ACRO Insights, and maybe Teri, if you'd mind walking us through what ACRO Insights is all about and how members may access this exciting information.
Yeah, thank you, Dr. Brown. So ACRO Insights, this is something that we really put together collectively around 2017, 2018. So it's been around for a couple of years. And really, we started out with just some of the different compliance components of really to bring information to radiation oncologists, kind of snippets of information, things that were happening from a compliance standpoint. We've gotten into different components of billing and coding. And lately, we've been trying to do also some more, deep dives into understanding even the payment systems and explaining some of that, how we even get codes. And we've done quite a few different articles over the last several years. And it's really kind of expanded and grown to provide sort of snapshots in a way, but information that is readily available and accessible to radiation oncologists that help them in some of their day-to-day stuff as well.
Excellent. Well, we're so excited to have all of you guys here and to talk more about the latest ACRO Insights article, focused on development of the Medicare Physician Fee Schedule. Definitely an important topic as we're coming into the new year. So I was hoping maybe Dr. Wallner, if you wanted to give an overview of some of the history of how the Medicare Physician Fee Schedule started.
Sure, I'd be happy to do that, since unfortunately or fortunately I was there at the start, at the birthing of the fee schedule. After Medicare was developed, billing was typically done by what was called UCR, usual, customary, and reasonable. So physicians could really charge whatever they wanted on a fee-for-service basis. And in the late 1970s, early 1980s, Medicare, the administration, it was then called the Healthcare Financing Administration, began to realize that they were losing control of budgets. They were unable to budget appropriately, and that physicians' fees around the country really had no coherence to them. And the other issue was that there was a clear understanding, even in the 80s, that primary care was suffering on the fee schedule, and the procedural physicians were earning more and more, and there was really a disincentive to primary care physicians. So in the mid to late 1980s, Medicare issued an RFP for proposals for restructuring of Medicare payments. And the ultimate winner of that competition was William Shao and his group of healthcare economists at Harvard Medical School, or Harvard University, actually, not the medical school. And they came up with what was essentially a relative value system, where they presumed that they would be able to assign a relative value based on time and stress and physician work. They began with about 8 or 10 different specialties and did not include, actually, in the first round, radiology and radiation oncology, diagnostic radiology and radiation oncology. Interestingly, at the same time, a group of prescient radiologists and radiation oncologists with people like Jerry Brickner, Bob Bogardus, Jim Moorfield in California recognized that radiology needed to take the first step in doing this. So they actually developed a radiology relative value system, which they presented to Shao. So the Shao group never actually did a radiology system. They took the radiology system that was developed by the American College of Radiology at that time, and they fed that into what their system was, the RBRVS. At around the same time, and this then was in the early 1980s or 1990s, the AMA recognized two recognitions. First, the AMA recognized that physicians needed to be involved in the development of the relative values, so they offered Medicare their willingness to take over the process. Medicare recognized that there was going to be a terrible political battle to develop the relative values, so they graciously accepted the AMA's role in developing that. So out of that offer by the AMA came the American Medical System, now called the RUC, the RUC, but what is officially the American Medical Association Specialty Society Relative Values Scale Update Committee, which is the RUC. And that committee meets and reviews both practice expense and work to feed to Medicare their recommendations for relative values, which are then fit into the Medicare Physician Fee Schedule. Medicare accepts about 95% of the RUC recommendations. The RUC is only advisory to Medicare, so Medicare does not have to accept them, but they typically do.
Dr. Wallner, would you help share a little bit more about how Professor Chow was, or Dr. Chow was put in the position to build this model? Or
Medicare issued, and this is typical throughout the federal government, what was called an RFP, a request for proposal, and groups from around the country submitted their proposals, and the agency, Healthcare Financing Administration, then HCFA, accepted Shao's proposal, and Shao's group was funded to develop the RBRVS, the resource-based relative value system. So the original system that was developed, they presented to essentially what then was the RUC.
Okay. And in terms of the RUC does not have a radiation oncologist sit on its panel. Is that correct?
That's correct. I actually had an elected position. The RUC is primarily representative of the major societies represented by the AMA House of Delegates. There is a seat for the insurance industry. There's a seat for the healthcare professionals advisory committee. Medicare has an advisory role. They don't actually vote. They have voice without vote because there's no need for them to vote since they have the final say on all relative values. But there are 4 rotating seats, which are 2 years each, and those are actually developed by they're nominated by the various specialty societies. I believe I was the only radiation oncologist who ever held one of those rotating seats.
I think that's a really important point for us to understand, that of the 22 seats that represent these major national societies, the one that most closely aligns with radiation oncology is the ACR.
That's correct, because the ACR has 30 plus thousand members. They obviously have a full-time, they have a very large contingent in the AMA House of Delegates, and they have a permanent seat on the RUC. And actually the ACR representative has episodically chaired the RUC. And the same is true of the CPT editorial panel, which feeds code definitions to the RUC. So new or revised codes are developed by the CPT editorial panel, and they then feed those codes to the RUC for valuation.
Excellent. Well, thank you so much for that helpful background. And as detailed in the ACRO Insights article, it's not just kind of the RVU or relative value unit, but also something called the conversion factor. That's important for actually how radiation oncologists and other physicians get paid. So Teri, was hoping you could give an overview of the conversion factor and how that's involved in calculating payments.
Yeah, sure. So I explained the conversion factor there, as Dr. Wallner talked about, there's these relative value units of the physician work, the practice expense, which is like your supplies, your equipment, your staff that are involved, and then your malpractice or the practice liability. And then it matters geographically where you're at, but that conversion factor takes that equation and equates it into a dollar amount that we recognize. So for that simulation, for that calculation, that IMRT plan, what that value of the conversion factor multiplies it into is a dollar amount that we recognize that it's $1,300, it's $100. And so when, that's probably one of the first things that I look at and when I'm looking to see what's Medicare finalized for the coming years to see what the value is, because overall that's going to affect all of healthcare. So not just radiation oncology, but if that, increases from year to year, you're going to see increases across the board. Separate, there could be changes to the RVUs, the relative value units, but if it decreases, then obviously there's payment decreases that we expect to see. So the conversion factor is an important factor, especially for physician reimbursement and those in the office or freestanding center to kind of understand what they're going to get paid each year. And that's really set by Medicare, but as sometimes happens, Congress can intervene and make adjustments to that and direct Medicare to pay a little bit differently than maybe what they had finalized.
Excellent. Thanks so much for that helpful overview. And I know that there have been, cuts to the conversion factor that have been endured over the past, multiple years. Jason was hoping you could provide a perspective from on the Hill, kind of how this factors into your discussions with staffers.
Yeah, happy to. And we should bear in mind that, there's a lot of talk about the conversion factor, physician payments under the physician fee schedule or conversion factor times RVUs. And so it's worth spending some time to talk about, what has happened to the specialty on an RVU basis as well. But specifically on the conversion factor side, there have been several years now of cuts to the conversion factor under the physician fee schedule. The most recent cut for 2025 is scheduled to be 2.8% relative to 2024. There were some efforts to mitigate that, and just this week, just today, we're trying to see where that goes, because the bill that had incorporated some of those mitigations was pulled out earlier this week, and then the bill that had the remaining healthcare items in it was voted down, and now it's looking like there's the potential for a government shutdown. So we'll have to see how that plays out. But what the AMA would like to do long term is to try to get a permanent inflation update to the conversion factor, and sort of consistent with other Medicare fee schedules, like the hospital inpatient, outpatient, ASC, SNF, all these other fee schedules have inflation related updates. So that's been AMA's big effort over the last several years, is to try to get something like that on the conversion factor side.
Yeah, thank you for that. That definitely makes sense. Just really trying to help ensure that we're reimbursed for the work that we do.
Yep.
Teri, if you would, it would be helpful, and the ACRO Insights goes into this in great detail, but for our listeners on the podcast, can you speak to the difference between the facility and non-facility payment rate formula and how that differs between those two locations?
Sure. Yeah, so when we think of non-facility, that's our office-based or freestanding centers. And that when we think about how you get paid in there, that's where, the physician may own that practice. They may own that actual, that office setting that they're working in or that freestanding center. And so when Medicare is valuing what they're going to get paid, they're thinking about, let's say, a simulation, for example. So there's cost that goes into the simulation equipment that you have, your staff, whether it's the therapist, you have a dedicated simulation therapist that's doing that, the equipment for contrast, the markers, tattooing, the masks and things that you might make. So there's some of that that you have to think about, that overhead in being able to do that simulation. And then overall, there is a malpractice value that's assigned by, how risky of a procedure really, and for the specialty that's performing it, what goes into that simulation. And so when we talk about non-facility reimbursement, we're thinking about the overall reimbursement for the technical stuff. So for that machine, that equipment, the staff and supplies, and there's also a physician component. You add them together because when you think of simulation, you can build like 77290 is our complex sim code. There's a technical component, a TC that can be billed, and then there's the professional component we usually use with the modifier 26. And so when we talk about non-facility reimbursement, it's really the total amount that you're paid in that office setting. But we know that there's a lot of physicians who are employed by hospitals or work in the hospital setting. And so they have to be valued, correct, into what the work that they're doing. So when we talk about the non-facility, that's really speaking to just the physician's component and what they get paid, because the equipment, the staff and supplies, and that is really the cost now of the hospital. And they're paid very differently under the hospital patient prospective payment system, where the physician is still paid their professional component. And when you look at the 7.7 codes that we have in radiation oncology, that professional component for our physicians, they're paid actually the same amount, whether they do that work in the non-facility or the facility setting. But it's really important to know when you're talking about reimbursement, what type of setting you're working in, because you're going to be looking at that difference in, is it just the physician's component in the hospital when they're looking at their reimbursement, or are they looking at the whole complete package, really, that global in the non-facility setting?
And it sounds like then, this unfortunately impacts those who are not in the facility setting in terms of what their overall reimbursement would be. And it would be great to hear from Dr. Wallner in terms of also, I know you have some points to make, but also to hear a little bit about, from the historical perspective, do you have some thoughts about why this dichotomy existed?
Yeah, first of all, when we look at physicians' component, when the Medicare Physician Fee Schedule was first initiated in the early 1990s, the physician component on a dollar basis was about 30%. So 30 cents on the dollar essentially was physician component, and 70 cents, give or take a little bit, was technical component. That's changed over the years to the point where now the professional component is only about 16 or 17%, and the technical component is overwhelmingly in the high 80s. Excuse me. And the reason for that is that so much of the cost of radiation oncology is technical. One of the problems that we've had over the years with the Medicare Physician Fee Schedule for radiation oncology specifically is that because we have multiple fractions that are very short spaces of time, the RUC uses a formula called IWPUT, which is intensity work per unit time. And when the neurosurgeons and orthopedic surgeons look at our work, they say, wait a minute, your treatment is 2 minutes or 3 minutes. And if you miss a treatment, if a treatment has a problem, there's not that much stress involved. So their point is that the intensity of our work, which is in short spurts of time, that the intensity is very low. So they value each of our interventions very low, and that's been a negative problem for us. The other issue which I might make about the conversion factor in the Medicare Physician Fee Schedule is one, I believe, of only one or two elements of the entire federal budget that has no inflation adjustment factor, and that's been a critical issue. And I've actually tracked this since the original, the first day of the Medicare Physician Fee Schedule. The conversion factor was $34, give or take some change, and Medicare calculates it out to 4 decimal points. And today, this year, or for 2025, it's calculated at $32 and 4 decimal points. So for practical purposes, physicians are being paid significantly less than they were in the 1990s because of the progressive reduction in the conversion factor. Periodically, because of physician pushback, Congress will require Medicare to increase it a little bit, but because there are millions and millions of relative values that are initiated by the whole house of medicine, each of those increases really is a very minor change.
That's very helpful. I would like to ask Jason, in terms of the discussion we've just had about this dichotomy between the facility, non-facility, what are your thoughts about how we might try to either equalize it or, help our legislative members understand how this is affecting the practice of radiation oncology and medicine in different settings?
I mean, I think the facility, non-facility thing is one of the least understood aspects, but I think, in my opinion, it's one of the most important aspects of the whole discussion about physician fee schedule reform, because there are effectively 4 sites of service where a doctor can treat. It's either the inpatient hospital, outpatient hospital setting, ambulatory surgical center, or what's called a physician office. And what is odd about the physician fee schedule that reimburses for the office is that the physician fee schedule includes 2 things that are very unlike. It includes the professional component, the fee for Dr. Smith to do the work that they're doing, but then it also includes this technical fee for the stuff, the high cost supplies and equipment, just in the office. The other fee schedules, the inpatient prospective payment system, the outpatient prospective payment system, the ASC prospective payment system, those are technical only. Those are, in other words, facility, it just goes to the facility for the stuff. And so what has happened over the last many years really is that, as probably last 20, 30 years now, is that as technology has advanced, like in radiation oncology and other interventional services, such that you can do these services safely and in a minimally invasive way in the freestanding office-based setting, those high-cost equipment and supplies have come out of the hospital outpatient prospective payment system. They've gone to the physician fee schedule, but the money's not gone with it. And so effectively what has happened is that the PFS, the physician fee schedule, has been subsidizing the hospital outpatient prospective payment system for years. And it's been diluting the physician fee schedule for everybody, for interventional, for primary care, for everybody. And so, what we are looking at right now as a college, and have done a lot of analytics around, is the fact that there are 300 services in the physician fee schedule today where the reimbursement is literally less than the direct costs, and direct costs being that stuff, that equipment, supply, those kinds of things. And that includes radiation oncology. And so, part of physician fee schedule reform should contemplate taking those things out that really should have never been there in the first place. It's, it's in the name. It's the physician fee schedule. It was set up in 1992 to reimburse doctors for the work they do. It wasn't set up, it wasn't contemplated to properly pay for a $4 million linear accelerator or a $6,000 stent. And I think when you look at things like proton therapy in particular, that is a really good sort of case study, because proton therapy, although a valuable service, is so, intensive in terms of the costs for proton therapy, that CMS has said effectively in their rules in the last several years, we're never putting this stuff in the physician fee schedule. It's just too expensive. And so proton therapy has been stuck effectively in a sort of a carrier pricing purgatory, meaning it's the rates are set by local carriers and there's no national rate. And so, things like the rocker legislation that pull out high cost radiation therapy equipment is a good idea. Other bills that have been introduced to pull out high cost supplies out of the physician fee schedule, that's a good idea, because it's again getting the PFS back to what it was supposed to be in 1992, which is a payment mechanism to account for Dr. Smith doing the work they're doing, not all this other expensive high cost supplies and equipment.
Thank you. That was very informative. I wanted to just take a minute, and I think Dr. Brown had asked, where can we look and find these ACRO insights? So any member of ACRO can access not just this ACRO insight, but all the historical newsletters that we've put out since Teri mentioned since 2018. A little different information, but they're all very useful and very helpful for all of us who are in practice. Dr. Brown, I thank you for the time.
Excellent. Yep. So thank you so much, all of you, for joining us. I know that we're nearing the end of our discussion. So just was hoping maybe from each of our guests, maybe one take-home message regarding this topic and what's important for radiation oncologists to think about with the Medicare Physician Fee Schedule. Maybe starting with Dr. Wallner.
Sure. I think the Medicare fee, Jason made a critical point. The Medicare Physician Fee Schedule was never designed to include practice expense or the technical side. It was really designed in the early 1990s for the physician payment. In 1995, Congress mandated that practice expense be included, and the AMA graciously developed a practice expense subcommittee of the RUC, which then took over that function, and it's functioned fairly unfairly ever since. I think whether we move to rocker or some other system, I suspect that there will never be a very fair payment system for radiation oncology on a daily fractionated basis. And I think it's incumbent upon us to work with colleagues throughout the country, and both in the hospital setting, the academic setting, the freestanding setting, to develop a global or episode-based or some kind of global payment system that covers all radiation oncology. I think the issue of the carve-outs, except for something that's fabulously expensive like proton therapy, that we need to be very careful of carve-outs, and we need to be sure that whatever system we develop includes the ability to bring in new technologies, because we are a technology-based specialty.
Thank you. All really excellent points. Teri?
Yeah, I think one of the important things, and something I try to stress when I'm talking with people and physicians, is to understand geographically where you're located. That makes a difference, and the setting that you're in, because you get questions, what do I get paid for the simulation? What do I get paid for that IMRT plan? And to know that it can vary. It very much varies where you are geographically. It matters for the setting that you're in. And know that, that also when it comes to that coding guidance and what you do get paid for, that can vary by your payers. So just even to be aware of having that information and know that it's out there. You can access the information from Medicare. They do have it on their website, and you can even go to your Medicare administrative contractors to get an idea. If you're not sure exactly what your payment rates are, you can plug that information in, and it's there for you to access. So I think it's just important to be aware of the information and what kind of goes into how you do get paid, whether you're using RVU models, a base payments, whatever combination, because ultimately the legislation and things that Dr. Wallner and Jason talked about do impact the physicians directly as to what they're getting paid.
Excellent. Very important points as well. And Jason, if you have any take-home messages?
Well, next year is going to be a pretty important year, I think, with a lot of the discussions that have been ongoing as it relates to physician fee schedule reform, site neutrality. There's going to be processes in place called reconciliation next year that will allow things to move on a simple majority basis in the Senate. We know that, it's public knowledge, the CPT panel has passed out a redefinition of the radiation oncology code set. And if that does go into the rule next year, that will be very impactful. We've got the radiation oncology case rate bill that we've been talking about. There's just a lot going on next year, and I think it's very important that radiation oncologists across the board, ACRO members, get engaged. It is super important to get engaged with the college, with your member of Congress, because it's going to be a all hands on deck situation next year.
Thank you. Yep, sounds like a very important year ahead with a lot of work ahead of us, but definitely important for all of us to work together, echoing a few points that all of you have said. I just want to thank everyone so much for your time and coming on to the show, and stay tuned for one of our next episodes.
Thank you, Anna. Thank you, everyone, for participating. And please find this material through the ACRO website and reach out to any of us if you'd like more information. The more that we're educated and know what is happening with this type of payment reform, the more we can get involved and help ourselves and our future patients.